Over next 9 to 10 minutes, I'm going to explain why use sheathless radial access. Rationale for using railway sheathless access system for direct guide catheter access. Even in 2019, the limitations of transradial approach essentially remains the same. Spasm is still an issue. Depending on institutional and operator experience as well as use of sedative medication as well as cocktails, there is variation in the spasm, and it's also a subjective evaluation of spasm. So people report different occurrence rate, but reality is that patients suffer pain during sheath insertion or sheath removal, or at times during the catheter torquing, and at times this spasm is severe enough that it does not allow catheter torquing, and at times the tortuosity of the radial artery does not allow advancing the catheter, and access has to be switched over to the femoral approach. Radial artery occlusion still remains Achilles heel for the transradial approach. Asymptomatic and sometimes symptomatic radial artery occlusion is a real issue. Depending on whether you are using a smallest equipment, using adequate anticoagulation dose, using patent hemostasis technique of just enough pressure to achieve hemostasis for the shortest duration of the time, and if these protocols are followed institution-wide, the occurrence of radial artery occlusion varies institution to institution. Majority of the operators do not objectively evaluate the radial artery occlusion rate, and therefore almost all the operator feels very comfortable that, oh, my radial artery occlusion rate is very small. But the reality is, when the radial artery occludes, you cannot reuse it. We know our patient needs multiple catheterization during their lifetime. You cannot use the radial artery for bypass graft, and particularly if patient requires hemodialysis, radiobasilic fistula is the best access for the hemodialysis, and if the radial artery occludes, that's not available for your patient. Inability to use larger catheter, particularly 7 French guide catheter in almost all the patient, but 6 French guide catheter in many of the small BMI female patient, remains a major limitation of the radial approach. If you think about all this limitation of transradial approaches because of the small size radial artery. If you look at the population distribution of the radial artery diameter, depending on which study you are looking at, the studies routinely report mean diameter of the radial artery. And if you can see that the distribution of the radial artery diameter amongst the population is a bell-shaped curve. At least 50% of the patients have the radial artery smaller than the mean diameter of the radial artery reported in the particular paper. You can see here in this paper, the mean diameter of the radial artery is reported between 2.3 and 2.1 millimeter in male and female in the Black, Asian, Hispanic, and white patient population. Now, this is the most important graph of this presentation. Here I have plotted outer diameter of the different 6 French sheath size. This is the outer diameter of the 6 French thin wall slender sheath. This is outer diameter of 6 French guide catheter. Here on 3 different lines, what you are seeing is the mean diameter of the radial artery reported in 3 different papers with the references here. So if you see here, depending on which paper you are looking at least 50% of the patient population have their radial artery smaller than the outer diameter of a 6 French thin wall sheath. More than 70% of the radial artery in the population distribution has radial artery larger than 6 French guide catheter. So irrespective of which data falls into your patient population, the chances are the radial artery is smaller than your 6 French thin wall sheath, and the chances are more than likely your patient's radial artery is larger than 6 French guide catheter. So whenever the sheath is larger than the radial artery, it tends to disrupt the intima, irritate the muscle, irritate the adrenergic system, cause severe spasm, leads to disruption of the intima, which leads to platelet activation and coagulation cascade activation, and eventually radial artery occlusion. This is not just a theory. There are substantial amount of evidence suggesting that whenever the sheath to artery ratio is more than 1, there is more spasm in compared to whenever the sheath to artery ratio is less than 1. There is evidence suggesting that if sheath to artery ratio is more than 1, patients are likely to suffer pain during sheath insertion and removal. And again, despite use of vasodilators and sedative analgesics, frequent occurrence of radial spasm in the female patients remain an important reason to switch over. Radial artery occlusion is a thrombotic process. As I explained, radial endothelial injury leads to activation of the coagulation system, and there has been direct support for thrombotic hypothesis of the radial artery occlusion. It's based on intravascular ultrasound, based on angiography, as well as pathological examination of a radial occlusion as seen with the references here. In a meta-analysis of 66 studies, the incidence of radial artery occlusion was found to be 11% with a 6-French sheath versus only 2% with a 5-French sheath, clearly suggesting that sheath to artery ratio of more than 1 is very important cause, or the most important cause for the radial artery occlusion. So early in our investigation of radial artery biopsy specimens, so we ask our surgeons to give us proximal and distal end of the radial artery at the time of harvesting the radial artery for conduit for bypass surgery. Half of this patient had radial artery use, other half did not. What we also ask them to give us is the distal end and proximal end, and we investigate this pathological examination. What was found is that the distal artery had much more signs of intimal proliferation and adventitia inflammation, suggesting that the distal radial artery suffered more significant damage or disruption by a sheath in compared to the proximal radial artery, because the proximal radial artery was only affected by the catheter. Similar results were seen on an OCT study where the intimal tear was substantially higher in the distal radial artery affected by the sheath in compared to the proximal radial artery affected only by the catheter. Many experts arguing against using a 7-French sheath through the radial access remains one of the major reasons for slow adoption of radial access in the United States, because particularly US operators like to use 7-French guide catheter for complex coronary intervention. Even if you think about in the Radial trial, experienced radialists, when randomized the patient to femoral approach, they use 7-French sheath in 6% of cases, while they only use 7-French sheath or guide catheter in a radial approach only 1% of the time, clearly suggesting that given an opportunity, the radial operator would like to use 7-French guide catheter. So if you re-examine the statement we made, it's not just the size of the radial artery, but it's the mismatch of the radial artery size to device is responsible for each of this limitation. Again, it's not just the size of the radial artery, but the mismatch of the radial artery size to device or the sheath is responsible for each of the current radial artery access limitation or transradial approach limitation. We know this very well, that for each French size, the sheath outer diameter is about 2 French larger than the outer diameter of the guide catheter. We use sheath because it allows us to get atraumatic entry and allows easy insert and removal of the device to reach to a destination for delivering therapy or investigation. And it prevents bleeding during the procedure, as well as prevents kinking of the catheter that's going through the sheath. But these things apply primarily for the femoral approach. If you can use a railway sheathless access system to allow direct guide catheter access, that will give you atraumatic entry into the artery, and you can use the catheter that is desired to go to the destination for treatment, then you can reduce the access size by 2 French size. The material involved in the guide catheter is very similar to the material in the sheath. Radial artery is a muscular artery. It's going to grab the catheter same as it does the sheath, and therefore the bleeding around the guide catheter does not happen in our 200 cases of our experience. Radial artery is a superficial artery, and therefore the kinking or compression of the catheter that happens in the femoral approach does not happen, and therefore sheath is not needed. So in reality, if you can get an atraumatic access in the artery with the guide catheter, you do not need sheath for the radial access. Again, it's not just downsizing by 2 French. It's not just that every guide catheter for individual French is 2 French size smaller in compared to the outer diameter of the sheath, but it is really the distribution of the radial artery diameter in the general population and the diameter of a 6-French regular sheath as well as 6-French thin wall sheath, which are both larger than most of the patients that you do transradial approach for. And in compared to that, a 6-French guide catheter is smaller than for most of the patients that you do transradial approach. The 6-French guide catheter outer diameter is smaller than the radial artery diameter of your patients. Again, it's not just the downsizing by 2 French, but it is the catheter to artery ratio less than 1, which can translate into reducing or maybe eliminating the pain, the spasm, the radial artery occlusion, and allow you to use 7 French guide, large bore guide catheter for complex coronary intervention. More than anything else, I have routinely switched my practice to use railway sheathless access system, which has allowed me to keep arteriotomy smaller by 2 French on every case. These are rather the reason for using railway sheathless access system or direct guide catheter access for your coronary intervention. Can we do that and hopefully eliminate or reduce the limitation of radial approach and allow more patients to have successful transradial approach? Thank you.